Estamos? Good morning, good morning, good morning. Thank you, thank you, thank you. Today is in English, it's not in Portuguese. You guys are tired of not understanding shit of what am I telling you in the last webinars on Instagram, receiving mails and phone calls saying, I don't understand your stupid Portuguese. Can you please speak in English? And yes, we're going to speak in English today. First of all, welcome to the season 2 of What Would You Do? This is episode 10, 10? Joe, this is 9? 9, episode 9. We had wonderful presentations from Dr. João Borges, prosthodontics, from Berta, from Mariana, from Mafalda, from João. Everybody presented. But now we arrive again to the implantology. What would you do? And first of all, we have a YouTube channel. In case of you don't know, we have a YouTube channel. It's a very nice channel. We already have almost, this is not updated, but almost 200 followers, okay? My daughter has 1,000, so I'm getting there, okay? But she has a program of trick shots, so this is dentistry, only dentistry. So, but we get to the 1,000 fans. But if you like our content, click like, or the bell, okay? The bell, it's also a good thing because you stay updated with the news that we're gonna share with you. So I think that there is a lot of people because we are in Easter holidays, okay? And I posted this video and Joe posted a video on the Academy and you posted. So I had everybody asking me things on Instagram that they normally don't ask. So I would like to thank you for the interaction. And especially there were a lot of postgraduate students from the University of Lisbon. It was very nice to talk to them again and some professors that are there. So it was a very nice discussion. They were very eager to see the program. So don't forget that we're gonna now enter a roller coaster of the treatment plan that we did on this case. But before we started, we are here, okay? Don't forget that we are here. We are in the heart of Lisbon. We are here, right? So May is going to come, so this is all going to be beautiful violet, okay, because of the trees that are very beautiful in May. So come, if you don't know the clinic, if you don't know the academy, just come and ring the bell and come upstairs and spend some time with us, okay? So this is the building, okay, this is the building. This is the most beautiful building in the whole Lisbon. I guess you agree with that. This is the most beautiful building, so come. You know, enter here, go to the second floor and ring and come to have a chat with us, okay? You're all invited, okay? So, I posted this case, you know, all the bells ring, the zygomatic guys click it, the sinus guys click it, the superiosteal guys click it, the denture guys click it. The denture guys, I think they're the endodontists, you know, these guys, they're more or less these guys, you know, let's do a denture is good, let's kill these guys of the implant. No, I'm just kidding with you guys. But everybody, you know, interacted with this post because it's a very interesting case. It's an atrophic maxilla, one daily case that we receive here, and I'll bet you also receive a lot of cases like this. And so, you know, it's a very difficult treatment plan. It's a very difficult execution, obviously, and you know, it takes time, it takes knowledge, and it takes also not only clinician cooperation, but also patient cooperation, team cooperation. Everybody has to be involved, okay? So this was the case, this was the scenario, okay? A patient, it's healthy, 60-year-old lady that came to our clinic and say, guys, you know, when I'm eating, you know, my denture falls on the soup, okay? And in Portugal, we eat a lot of soup, okay? We basically eat soup all day. So she wants to have a stable teeth, okay? So I brought you these couple of options. What are you going to do? So do we say, oh, no, you did a very bad denture. I'm a good denture guy. That was my favorite discipline in the university. I always had 20 over 20 in the university. So Mrs. Amelia, I know how to do denture. Sit down, I'm going to do the best denture in the world. But that's an option, okay? Then you can go, well, severe resorbable maxilla, so zygomatic implants, I think it's the best option to go. Some of you guys voted this. Some of you said, okay, it has good sinus, you know, no pathology, so maybe a bilateral sinus lift with implants would be an option. And last but not the least, the new generation of 3D printed subperiosteal implants. These guys are also very strong, you know, and they voted in click and said, let's just do a subperiosteal implant, so no grafting, no traditional conical implants, just open the flap, put a titanium mesh, and just rehabilitate. That's a subperiosteal guys. So, results, okay? 42% of you said go to the sinus, okay? Nice option. 28 of you said, let's go for the zygomatic implants. And 17% of you, almost 20%, said, don't touch the case, just give me a new denture, okay? I don't know these guys. Who are these guys? I mean, a patient comes to you and said, I don't want a denture, and then the treatment plan is, is that you? João, how come you voted for the denture, okay? You know, the patient comes, she wants to get rid of the denture, and then you give a new denture. So, that, you know, that's completely, you know, kick out the implant dentistry. The last 70 years of implant dentistry said, no, this is not reliable, you better have a good denture, okay? But, you know, it's an option. And 40% of you said subperiosteal implants. You know, let's go and place subperiosteal implants, okay? All, you know, valid options to do, okay? So you also want to know the number of people that voted. It's very important. Someone asked me that the other day. How many people voted? Well, we have more or less 30, 40, 50 people that voted on Instagram. Depends on the topic. You know, and basically 15 of you said sinus lift, 5 of you said subperiosteal, and 6 a good denture. So it's more or less balanced, you know, but the sinus lift seems that, you know, the ones that is going to win. And before we jump in the treatment, don't forget that this is obviously a clinic, a team approach to the case. It's never about one guy, you know, solving the problem. There is no professori that, you know, can handle all these hard cases. It's all a teamwork. And we have a lot of fun, you know, rehabilitating these cases. But in this particular case, we have 2 guys that help, you know, build the case. These are world-class prosthodontists, you know, the best in the world, the best of the best, the elite group. And I'm very fortunate to work with these guys. So these guys were, I only did the part of the surgery, but these guys went and did, you know, all the case. They worked together in this case for separate reasons. But, you know, these are very serious guys. They know what they're doing. They never party. So they are really reliable on the way that that they treat the patients, okay? So, you know, you don't want another guy to treat the case. You want these 2 guys to treat the case, okay? So we had a lot of party on our 3rd anniversary, okay? So the case is not only the upper. This case was upper and lower. You know, all of them were difficult to manage. All of them were difficult to solve, okay? So the first thing that we did was to remove the old implants on the lower. That's where João came in and gave a little help on the immediate loading procedure. As you can see, the lower is probably as tough or more tough or tougher than the upper, because you see it as extremely resorbed mandible, you know, with the inferior alveolar nerve popping up, mental nerve popping up from the alveolar crest, no keratinized tissue, no nothing. So we get to plan this case and enter to do a full mouse rehabilitation on the lower, you know, first to regularize the lower plane, so we can have a very good denture on the upper that's occlusionally stable, okay, for the patient. This is where the prosthodontic enters. So always, implant dentistry is a prosthodontic-driven therapy, okay? You don't care about the perio, you don't care about oral surgeon, you don't care about all of that stuff. The prosthodontists are the ones that have to, you know, really stabilize the way that the patient is biting and occluding, okay? So we did. We got to a point where we chose the best macrogeometry, and the secret of the upper is to choose the correct macrogeometry of the implants. In the lower, in this case, we had an immediate loading procedure, and we know, and in some cases, we're going to fenestrate. So why not to use polished color type of implant in this case, knowing that is going to be, out of the bony walls. So instead of you trying to graft all this resorbable mandible, just, place the correct implant for the correct site. And you can see over here that this is a polished color, so it may stay outside the bony walls against the connective tissue. And so João beautifully, entered and did the immediate loading procedure of this case. As you can see, followed the guidelines, the occlusion, the central midline, there's space for cleansability of the patient. Now you see that the plane is regularized here, so the patient is biting well, so there's no Kelly syndrome here. Everything is as it's supposed to be, so it becomes easier. So when I have to plan the upper, now I have a proper guidance to follow, okay? So this was the result on the lower, okay? This is the immediate loading procedure of the lower. This is the Straumann 3.75 NT polished color implants. As you can see, it's outside the bone, but this is polished color here, so the mucosa, this is a tissue level type of implant, so the mucosa goes and attached firmly against this type of macrogeometry. So choose your implant correct. If the guys of the post-graduations are hearing me, choose the correct macrogeometry is the key for the long-term maintenance of this implant. So this is our baseline for the upper, okay? So here's the upper. Extremely resorbed maxilla, okay? No bone, and now we have to decide what we're gonna do. So we activate God mode. I'm becoming dyslexic. We activate the God mode, okay? The God mode, and now we're fully powered, okay? Okay. So don't forget that it's good to be on the God mode, okay? I feel like, this, how do you call this guy? It's Son Goku. I feel like Son Goku, when they go, I know all of this stuff, I know the literature, I know the techniques, I know the outcomes, okay? But watch out with the God mode. It's extremely important on your team that you have people that don't let you get in the God mode for too much, okay? And I have two people that work with me that never let me go into the God mode more than 10 seconds, okay? Because they bring me down to my humble planet Earth every day of my life, okay? It's my beautiful wife that she's making exercise at home. Darling, if you're seeing this, I love you, okay? I'll bet she's at home watching this. So this is Elena, my wife, orthodontist, so she is the one that wakes up every morning and said, you're a shitty guy, go and do your best in the morning. And there I go, wake up, and every case, it's like, I'm gonna be the best, because I have to go the best. And there's Liliana, my dental nurse for the last 10 years, okay, that when I'm entering the God mode, she looks at me and said, are you in God mode? And said, yeah, I'm on God mode. So can you please bring to the humble mode so we can do a good surgery? And then after 10 seconds, I go to my humble mode, and there I go again, try to be the best in every case. So never be on the God mode for more than 10 seconds, okay? Because these ladies also, like João, they don't like to party, okay? We don't like to party here at the yacht. We never party, okay? It's always serious business stuff. No parties, even with Elena and Liliana, okay? So, how to activate the brain mode, the humble mode? Okay, let's look at this case and try to see what is the best option. Like I told you, there is no wrong options. All the options are valid, okay? Except that when you think, you have to do an evidence-based approach to the patient. And an evidence-based approach to the patient, it's not what has the better research. It's not only that, that is a part of the equation, but it's also the patient needs, the patient profiles that you have in front of you, and also your expertise, okay? Your expertise, your clinical expertise is of extremely valuable. For example, between zygomatic implants and sinus elevation, we have the guys from the Zaga centers, they do beautiful zygomatic implants, beautiful cases. It's all good. It's a valid option. They have wonderful long-term results you can do. But except in my hands, the sinus elevation works better than my zygomatic implants. So I bet if this lady went to Barcelona for Aparicio, we'd probably do wonderful, beautiful zygomatic cases. But here in Lisbon, my expertise is more the sinus elevation. I dominate better the technique. So it's always like this. After you see that they all have long-term follow-ups, you have to choose a technique between the patient and your expertise. That's evidence-based approach. So in this case, okay, my approach was the sinus elevation and 42% of you chose also this option. This option is the one that has more long-term follow-ups, the sinus elevation, no doubt about that. And within my hands, within my clinical expertise, is the one that works better. And especially this case, this lady was not in a hurry to have immediate loading, immediate fix this. She lives here, so she can wait a couple of months before has the implants. So everything combined, you do the decision about which is the best option for this patient. Of course, can you go for the zygomatic implants? Of course you can. Of course you can. As long as you know the protocols, you know the outcomes, you speak to the patients, then zygomatic implants is also an important weapon that you have nowadays. In old times, you would say zygomatic implants does not have the research to be a valid option, but that was 20 years ago. Now they have, very good follow-ups on the case, very good literature, so it's an option. The subperiosteal implants is the newer therapy, okay? We had one in the past, it is different than one now. In the past, subperiosteal implants did not work very well, but I understand that with new technologies and 3D printing and more fit frameworks, it may work, but it obviously needs much more literature to support this therapy. And the last, the new denture, yes, you can go for a new denture, but don't forget what P.I. Brandmark said before he died, okay? No one should die with their teeth on a glass of water, okay? And today, it doesn't make any sense at all, that if the patient wants a fixed solution, that he receives a denture, okay? In my opinion, it's a no-no. We have wonderful surgeons around the world. We have extremely good evidence on implant dentistry, so there is no reason for a patient that wants a fixed rehabilitation not to have one, okay? So although I agree that you can do a new denture, that was not, the patient needs and wants, so we're not following the patient's needs and wants. And basically, if you don't know how to do it, you can always refer to another type of surgeon, okay? So we went for the sinus lift procedure. Joe, close your eyes, okay? Don't look at this. So this is heavy stuff, okay? Now this is an extremely resorbable maxilla, okay? Follow the sinus guidelines, okay? Now you wanna, this is no Mickey Mouse stuff like Romanos would say at NYU, okay? You can do some Mickey Mouse stuff in some sinus, okay? Just go minimally invasive. This is not the case, okay? This is, you wanna create bone, okay? You wanna create bone, you don't wanna create soft tissue, you don't want to create, mushy tissue. You want bone. So you have to go open a fairly good window with your piezo, try to lift the membrane or the bone membrane without tearing the membrane. Then go gently with the good instruments, squeeze the sinus membrane towards the medial wall, okay, where the blood supply is, and then you start to, working your area so you can have a very good, chamber for osteoconduction, so all your graft materials can maturate and eventually build a good bone. So what you see here, it's an open lateral wall, okay, with the membrane open towards the medial wall, and here you see some collagen membranes, in order to contain everything in place, okay? So you let the sinus maturate, and after 6 to 9 months, I don't remember more or less, probably this was more towards the 9 months than to the 6, you enter and you place your implants, okay? Now you have regenerated bone, and now you're gonna place your implants according to the bone that you have there, okay? So this is implant placement, okay? This is at stage 2 procedure, okay? The implants stayed submerged in the first area. Then we did the second stage. We open and place the intermediate abutments, okay? Then we place the cover, and here is the result of implant placement, okay? You have a good AP distribution. You have 2 implants on the tuberosity, 2 implants on sinus graft, and 2 implants anchored in the nose cortical, okay? And as you can see here, the before and after, You see the sinus elevation here, the sinus elevation here. By the way, these are not short implants. This is a 12mm implant, okay? It looks short because the sinus is really grafted, okay? This is a 12mm implant. This is a 12mm implant. This is a more aggressive type of thread, more aggressive type of thread. This is an apical tapered implant, okay? So you can squeeze within the corticals of the sinus and the nose cavity. This is an apical tapered one. This is also an aggressive type of one, and this is also a tuberosity implant. So if you look at the cut, okay, that's where your implant geometry matters for this case, okay? If you're gonna squeeze an implant between the sinus and the nose on this type of patient that is a thin cortical, you better rely more on your implant preparation and do not have a very compressive implant. You know, just squeeze them in, you know, let the implant in without having too much pressure on the walls. On the other side, on the sinus elevation one, you want compression. You want the big, you know, the big one, the one that is gonna enter like this and get the primary stability of this type of bone. And so here you have another case of the implant that was placed here on the nasal fossa, between the nasal fossa. See here? Are you see here, João? You see here? Are you see, Joe? You see?
Yes.
You see? You see, Mafalda? This is a nasal fossa. If you place an implant that is too aggressive here, either you break the sinus or you break the nose, okay? So it's very gently you squeeze this implant, and the stability of these implants are amazing. So here's an overview of the two implants anchors. So what did you do here? Yes, you did a sinus elevation, okay, for two implants, but the other four, they're not on the sinus. One, we ceased to take the advantage of the corticals of the nose, and the other ones, we went for the tuberosity, okay? Let it heal for 3 months, and then low, okay? So this is a picture of the stage 2 procedure, okay? So there, João entered to reline the denture, and what you have here in the middle one is that you now have to work with angulated abutments, okay? Because these implants that stay on the nasal fossa, they enter more or less with 30 degrees of angulation. So you need to correct this on the procedure. See, this is the raw part coming out, okay? So you have the denture here, relining the denture. Here you have an overview, okay? This is another overview on the position of the implants, okay? A very good AP spread distribution, sinus, nose, and tuberosity here. And you can see here the picture already with the right transepithelial abutments, okay? The 30-degree angulated implants. This is a Straumann BLT with a 30-degree multi-unit angle abutment. This is the BLX placed in the sinus with a 70 degrees angled abutment. And these are the tuberosity ones placed over the sinus with a 30-degree angulation, also BLX transepithelial abutments. And you can see here the provisional after relining, a fairly good distribution of the implants. We're not too bulky on the palate because of these angulations, but we have a fairly good stability that leaves room, you know, for all the space for the patient to maturate and bite, okay? So this is the relining of the denture. As you can see, a good AP spread on the tuberosity part, on the sinus elevation, and now the patient is ready for the final restoration, okay? This was our option, okay? It may not be your option, it was our option. Every option is valid according to what you can do and the patient needs and wants. So in this case, you know, the team is of a lot of hard work from the team, but what matters is the patient, she is very happy with the situation that was not an easy situation to solve. She is very thankful, not to me, okay, but to the whole team, okay? And that is more important. The credit to the whole team that in fact were the ones that solved this case very beautiful, okay? Thank you for being there, okay? Next week we have endodontics, okay, with a very nice case. So stay tuned in to our page and have a good Easter holiday, okay? Bye.